Hey, it's Jim Prevost with Embrace the Shake. Screen's awful grainy tonight, and sorry for the backlash on the lights. But I've had a light burn out here in the room in a minute, and I can't climb a ladder, so we're going to try to just go ahead and press on. Tonight's Hey Penny, Marcus, how you doing? Good to see you, Mark. Bobby, thanks for coming on board tonight. Tonight's subject, hey Crystal and Becky, good to see you, is going to be dealing with depression. And as some of us call it, going down the rabbit hole. But I found some research in uh, a magazine called Brain and Life, and it talks about tips for people with Parkinson's, epilepsy, and stroke. So I thought maybe it's a good idea that we talk about that tonight. Hey, Bobby King, my brother-in-law. Love you, brother. Aaron, thanks for being on. Terry Peterson. Hey, brother Don Pullum, like your watch. That's a heck of a watch, Don. Almost as good as my assistant principal's watch. Kenny Freeman, Eleanor, good to see you. I just appreciate everybody being on. As always, I see that I'm frozen. I'm back. Sorry, I'm frozen. Apparently, Chrome's having some difficult issues today. I've had trouble at work. I'm having trouble now, so we're moving on. I'm going to have not some extensive notes tonight, but some things I underlined in the article that bring to mind some of. Hello, Ed Blake and Libby. Good to see you. Rachel, thanks for coming on tonight. Penny, as always, thanks. Enjoyed you at boxing yesterday. The notes I have are derivatives from the article I read, and I'd like to address the issue of depression, as I mentioned earlier. I don't know if we already froze up or not, but anyway, there is a significant correlation between. Hey, Daryl, how you doing? Hope Miss Beth is with us tonight. There's a correlation between depression and stroke, depression and Parkinson's, depression and early onset Alzheimer's or any stage of Alzheimer's, and a correlation between epilepsy and depression. And I'm going to surmise I'm sorry, I'm a little bit scattered tonight. There's a direct correlation between epilepsy, Parkinson's, and stroke and post-event depression. There's also a correlation that says that folks that are already diagnosed with clinical depression or depression of any type that's being controlled medically within 2 years develop signs of epilepsy or Parkinsonian behavior. Parkinsonian behavior can be Parkinsonism, Parkinson-like, or Parkinson's itself. And at that time, sorry, that's Moose whining in the background. So I thought what I would do is tie that in specifically to what I've seen with Parkinson's and what I've seen with dementia. So let me address with dementia. First of all, I have a friend that reached out to me, and because of through Messenger, and advised me that they had been recently diagnosed with early onset dementia or young onset. They're changing the name of it because, excuse me, and I apologize for the yawning. It just will happen as part of Parkinson's. And it was suggested to me one time, if you're yawning so much, maybe you don't need to have your show. Well, maybe you need to see, the individual made that comment, maybe you need to see the yawn and really learn what Parkinson's is like. Anyway, this person does not live near Shelby anymore. They've moved. And the comments were that, I feel myself slipping every day. And hey, Rex, how you doing, buddy? I feel myself slipping every day. Life is getting more difficult. And I feel like, I'm not going to do well. I'm not going to beat this thing. I'm not going to survive. And so that kind of, you know, motivated me. I'm sorry to push me for that way. Motivated me to talk about depression. And as we know, there's physiological depression, which deals with the body breaking down and not producing the neurochemicals. And at the same time, um, there is clinical depression, which involves the neurotransmitters that deal with mood, cause massive chemical drops, and develop those signs that are self-depriving, so to speak, like loss of self-esteem, loss of ego, becoming isolated, um, sometimes delusions, because the three Ds do hang out together: depression, delirium, and delusion. And depression, dementia, and delusion. And so that ties in quite well with how depression can be caused by a neurochemical or caused by a physiological event. And it can also be caused by too many lifestyle stressors, which causes a higher level of cortisol, the stress hormone, which can cause terrible effects on the psyche and also the physiology of our bodies. So I'm going to move on away from the depression and the Alzheimer's, because I've got to be really honest with you. I'm not well versed in it quite yet. I'm sure I will be within the next couple of months, but I do know about depression and Parkinson's. And I do know that I would say almost all of the folks that I'm associated with that have Parkinson's, inclusive of myself, have had bouts of depression or depression-like behavior. And not necessarily does that involve the traditional types of depression signs. There are some hidden signs that we kind of keep to ourselves. And one primary sign of somebody that has Parkinson's is in a depressive role or is in a depression bout is self-isolation. And that's where they don't get out much, or they don't want to socialize much with people that they even know, like family. They don't want to go places. They just rather stay more or less postured up in their favorite chair, watch television, and just stare. Sometimes go off into their own place at times, sleep a lot, don't eat well. And the other behaviors associated with isolation. I will have to say, as you well know from watching the show, that initially they thought I had dementia, Lewy body dementia, before I was diagnosed appropriately by Dr. Klein with Parkinson's disease. My first diagnosis was chronic pain with associated neuropathy in my arms. And then I was diagnosed with carpal tunnel and brachial plexopathy. And then I was diagnosed with potential dementia and Lewy body type. And I apologize for Moose, but I'm just not going to discipline him right now. And at the same time, Moose, Fooey, excuse me, Fooey. Then Dr. Klein, I went to see him, and he gave me a large battery test and determined that I needed to have an MRI. In that large battery test, he did test me for depression, because he said I wasn't the bubbly fella, as he would say. Hey, Bob, good to see you. Colin, good to see you. Jessica. I wasn't the bubbly fellow that he'd known for about 20 years. And I think it was just because I was having so much trouble with my organizational skills and remembering things in people, places, and time that I think it did cause some depression, neurochemical depression. Anyway, as soon as I started on my medication for Parkinson's, within a matter of a month, that disappeared. So I'm just to be, transparent, as they like to say now. I feel like I did have a bout of depression that was driven by the low dopamine, which is a mood medication, also with motor. Um, so I think I was a victim of that, and um, I have not had those episodes since being on the dopamine medications, but I have had bouts of lack of activity, getting out and being engaged. And that's part of the motor issues that go along with Parkinson's. Um, the depression that most Parkinson's colleagues of mine that they encountered usually occurred either at the end of the long diagnostic process or within a year's time after the diagnosis. In fact, I have one friend that, excuse me, that said that they were diagnosed with depression prior, and that because of that depression cycle that they were in, it kind of blinded the physician to other underlying causes. In addition to that, physicians that treat us with for Parkinson's disease sometimes become some involved in the Parkinson's disease, chasing symptoms and signs and trying to get your meds right, that they forget about depression in some of the unannounced. Or how you doing there, Sergeant Marlowe? Good to see you. Thanks for being on with me tonight. Like I said, sometimes they become so engaged or so involved in trying to chase down the Parkinson's, get your meds right. They look at the hidden signs, the secondary non-motor signs, like loss of smell and taste, and loss of self-esteem, and then eventually depression. So I have a couple of other things that I want to talk about. The new therapies are out. Some of them are old, and I may be reading directly here, but there is a lot of material that I'm trying to condense because of the time limitations I like observed tonight. And these are known as therapies for, excuse me, persistent depression. And this is used within a combination of antidepressants. And what I'd like to say is not only that they use antidepressants and they use talk therapy, but those antidepressants are prescribed after lengthy rounds of seriatic blood work to determine where a person is as far as their hormones and blood chemistries. And then they titrate the medication to meet those chemical levels that are in the blood. Now they have given you medication specific versus medication generalized. And then they send you to a psychologist or a psychiatrist that is mood disorder or depressive disorder specific. And they try to work on the triggers that have brought about that depression other than the Parkinson's. So it may be PTSD from some time overseas, or a traumatic event in a personal life, or an LEO, law enforcement officer, firefighter, EMS, first responder, is seeing a bit too much, and it's starting to roll back onto them after or even before the Parkinson's disease has been diagnosed. As I said before in a previous several previous live casts, that uh, Parkinson's usually hides its ugly face in other symptoms and signs for about 2 years before you're formally diagnosed. And therefore, the dopamine level is low and it can hide itself. The depression can hide itself, and the Parkinson's can hide itself where you can be physiologically sick. And that's the physiological depression I was talking about. The lethargia, the fatigue, loss of motor coordination, discoordination, those things like that are seen as physiological depression when realistically several of those can be shared with depression. It's what they call concomitant etiology, meaning the study of diseases that work together that become synergistic. Um, so the first one I'm going to talk about is the deep brain stimulation, and this is where they go into your head. You're awake during that time period, and this simulator is a small device. It's implanted underneath the outer layer of your skull, your hairline, and your skin, and your fascia layers. It's not very big, and then while you're awake, they interview you, have different motor control things that you need to do, and they implant these electrodes into the brain tissue. And what happens is they go ahead and regulate it in the parameters that they need. And this electrical stimulation is, hello, Jimmy Martin. This electrical stimulation is infused into the brain, and it's supposed to, according to what the literature says, and work along with the medication to help with the neurotransmitters that work with the motor and the cognitive. Next thing is called transcranial magnetic stimulation, and this is almost, how would you say, hocus pocus. However, um, this is where they take, it's less invasive than the deep brain stimulation. Um, it doesn't involve going into the skull or the cranial tissue or the skin or anything like that. But they take this device that's full of magnets, and what they do is they press it onto your skull, and the magnetic waves pass into your brain. Now, this is done over a period of time. I apologize again. A period of time about 4 to 6 weeks long, and you go 4 to 5 times a week. Now, I don't know how long the sessions last, um, but the results clinically here states that um, it's considered to be associated with the old practice of electroconvulsive therapy, which has now come back through the medical practitioner, and it has been revised. And at the same time, they say it's just not, they don't know if it's more effective than the medication, but they have found out that if they couple it with medication, that the patients do improve, and the episodic or the persistent levels of depression subside, and at the same time, motor control does improve. And then the final one I want to talk about is ECT. This is electroconvulsive therapy. They used to use this in a more, I would say, brutal form in the 50s and 60s. What they do now is that they administer general anesthesia to the patient. And what they do is, after the patient's under general anesthesia, they introduce this electrical current through the brain. And what it does is it causes a convulsion, um, a hard tonic-clonic seizure, which is tone and clonus, where your body postures. And what that does is help neurotransmitters to be flooded into the brain. And there's been some reports that it completely resolves the types of seizures, the types of depression, or at least mitigates it to where the time period between episodic bouts of depression is widened, the so-called sweep of depression. So that's the different types of therapies. Bob asked if there's any thoughts on marijuana and depression treatment. I have some friends that smoke marijuana on a regular basis, and they said it does improve their mood. It also helps them with higher levels of maintaining motor control, tremors decrease, balance improves. The only problem is that after the marijuana, the THC effect has gone down, Bob, they realize that they're going to have to self-medicate. And the question that they have is, the effects are longer lasting, but the cost is a bit prohibitive now. If the United States government would provide medical marijuana to those that require it in the state of North Carolina, other than a pill, much like the marijuana card carries in California and some of the more liberal states, then I say, why not try it? Anything that helps any medical disorder, that's an alternative therapy, I think is a good idea. Hello, Jada. Good to see you. It's been a while. Great former student of mine, student athletic trainer at Birds. Okay. Let's talk about some tips with dealing with depression. First thing is the best treatment known or still has considered to be the gold standard of depression for treating depression is antidepressives that are chemistry specific, meaning they match your body chemistries. They just don't give you the let's try this dose because people your body weight can take this. They do a blood study. It doesn't take long, a week, and then they helps them choose the type of uptake drug they want to put into your system, and they couple that with talk therapy, seeing a psychologist or a licensed professional counselor or a psychiatrist. The evidence is abundant on that as far as how that helps folks with depression from all avenues. But the research is astounding that combining antidepressants with Parkinsonian medications and cognitive behavioral therapy, that there was a significant turnaround in the status and the gradation of those with Parkinson's disease. So let me qualify that really quick. Let's say you're a stage 2 or 3. Let's say you're a level 3 Parkinson's patient and you're really coming a 3 plus, almost into a 4. And then you enter into this type of therapy. What happens? Please accept my apologies again. They take your blood, they take a wide series of blood studies, and then they initiate the blood study along with talk therapy, cognitive behavioral therapy, and there's Moose again in his crate. And then along with the dopamine that you take and an antidepressant. And that would delay the time, according to what the studies say, significantly, where you may move out of a 3 plus going towards a 4 back down to a 3, mid-stage 3. So, hey, why not roll the dice and try it? And they did this with about, see if I can read the number, 1,700 patients over a 3-year trial period. And the study concluded 2017 by the Movement Disorders Council. Talk therapy by itself, cognitive therapy, what they call cognitive and behavioral therapy. This is number 2 on talk therapy. It seems to be the best as far as antidepressive behavior. The thing with this type of therapy is they really focus on the triggers that create the depressive episodes. They focus on the environment the individual lives in, what type of career that they have, what they do for enjoyment. So essentially, they dissect your life. They don't want to see if something in your life as a child messed you up, or you haven't resolved your Elector complex or your Oedipus or anything Freudian like that. What they look at is at your environment with about 5 years prior to your disease diagnosis. And then they start delineating, they dissect that down. And then they try to provide avenues and pathways to decrease the negative hormone effects from the depression and the negative points in your lifestyle and the negative exposures that you have. Moving on into the holistic approach is the mind body. And in the mind body, they talk more about the depression anxiety cycle, which is just awful. Hello, Megan. It's good to see you. Man, I miss working with you at Shelby High School and seeing you. It's been too long. Anyway, with the anxiety depression cycle, I want to talk about simple anxiety. And what I mean by that, because all of anxiety is complex, but kind of a simple explanation would be that anxiety is an increase of awareness causes you to be hyper aware of what's going on with you. Thank you so much, Megan. All of us at the house appreciate that. Anyway, the anxiety can be triggered by being unfamiliar or having a sense of not feeling comfortable in social environment, not being comfortable with yourself, not being comfortable with what's happening to you. And then the depression is neurochemical or neurophysiological, whatever they determine. And what happens when those two cycles don't resolve, you develop depression, and then you get anxious about your depression because you feel out of touch, unable to do things, you kind of dysfunctional. Fooey moose, fooey, fooey. I apologize. And then the anxiety causes more depression, and more depression causes more anxiety. So it's that cycle. And that's usually caused by a loss of chemicals working together. The chemicals not working together, they're working against each other, but they can't work with each other because then they're not at the right levels to work together. One may be up here and one may be down here. And the gap between the two chemicals can't synergize or come together. So that causes a loss of multiple functions. Well, what one of the therapies said in the Journal of Medical Association, neurologist particular journal stated that what would be good is provide a holistic approach where we have mind and body. So how this goes down is that you go in for a top to bottom physical, a top to bottom chemical, a top to bottom dietetics, and a top to bottom psychosocial evaluation. I didn't say psychological, I said psychosocial. Then you go in for neuropsychological testing. So this process takes, a couple weeks maybe if all your, hey, Coach Brooks, good to see you. Hope you're enjoying your retirement. Sergeant Rooney, good to see you. Eric Cash, hey, my boy. Eric Cash, great football player at Gaffney High School, wrestled as well, and I believe served in the Air Force and is a veteran. And I just think the world of him. Eric, I hope life's going well for you and going better. You're always on my mind, my friend. Coach Brooks, I want to say thank you. Being from Kings Mountain, you understand those Southern values and all the many things that you did for all the guys at Clemson, Tennessee, and all the places you coached, teaching young men how to grow up and be men. I just appreciate you. And you always made yourself available at Shelby High School. I just remember that so much. Anyway, getting back to conclude on this mind body therapy. Once the team does this and works together, then they develop an entire mind body a paradigm of care. And this involves Tai Chi, meditation, low levels of medication, just to take the edge off, a reconfiguration of your diet, a full exercise plan, and constant studies of your blood work, your hormone levels. It's an expensive adventure, but there's so many research study now into the alternative practices that the study folks mentioned that most of the folks that are involved in these therapies are part of research studies and aren't involved with any fees. What happens is they have 8 weekly sessions a week, 90 minutes over 8 weekly sessions. So you got 7 days a week. You might be doing 2-a-days. So you never know. I've never been exposed to this. And then finally getting into the exercise component, as we all know. All the journals reviewed recommend 150 minutes a week. And all the journals also recommend a Mediterranean diet, which puts you in ketosis. And they found that exercising and being in a Mediterranean diet, and along with your medications, provided significant relief, not only of the depression symptoms, but Parkinson's issues and issues with post-stroke and epilepsy, as far as diminishing the frequency of epilepsy episodes, and also seeing great bounds in folks coming through stroke therapy, the physical therapy, the occupational therapy, and the speech side. So those are the 4 tips dealing with depression. I hope that's helped. I know that my discussion about depression was somewhat clinical, but not lengthy, and I just thought I'd keep it simple. But let me say this in closing, that folks that are diagnosed with Parkinson's are 3 times higher within a diagnostic year of developing depression. And some of the signs of this depression are, first, the loss of sleep. The second one is a rapid decline in overall physical health and an increase or exacerbation of the Parkinson's syndrome. But the other scary, how would I say, the scary part about depression associated with Parkinson's is that Parkinson's has a 2-to-1 ratio, meaning that Parkinson's folks that have depression are twice as susceptible as being protein deficient, prolonged disabling depression, which means that the levels of our protein in our brains reduce so low that the depression becomes debilitating, and the brain becomes protein deficient to a point to where restoring protein levels in the brain would be extremely difficult, and most likely not successful. I want to thank everybody for being on tonight with me. You guys are great support. I tried to keep it around 30 minutes. And I just want you to know that from all of us in Parkinson's land that are in our boxing class, we thank you for your support. Embrace the Shake is getting bigger. Our T-shirts are supposed to be ready in about a week or so. Hopefully reality will happen soon. At the same time, please, if you have somebody in your family that has a motor disorder or a cognitive issue and impairment, or is suffering from an illness that's debilitating, please spend time with them and make those visits count, and make the many memories that provide strength. So I'm going to close it out for tonight. You can see I'm kind of worn down. Thanks again to our police and fire and EMS. From a personal note, I'm so glad that Tim's Rakeen's trial was resolved by the assailant who murdered him, pleading guilty. I have my own thoughts on that, and I'll just say I wish they'd given him the death penalty, and I wish they'd execute him. But I probably shouldn't say that. Heck, I got freedom of speech, and I defended it. And Tim was my friend. Thanks for all the soldiers and sailors, Marine and Airmen, and coasties that keep watching and keep us safe. Thank you so much for all that you do, Sergeant Rooney. I know you've been deployed a couple times, and thank you for keeping us safe and giving us our freedom. So I'll see you this time next week, and we'll have a special guest, actually, hopefully two at one time, but they'll be coming here to the Prevost Manor in Crystal Springs Estates. And it was good to see everybody. Love you. Mean it. God bless America, and always embrace the shape.